Okay, thank you very much, Alonzo. I'd like to thank you guys for coming out today. I'd like to thank Dr. Curtis Chastain, Pennington Biomedical Research Center, and all the sponsors that have helped put this together. I think this is a fantastic community service program. So we're going to start off by talking about prostate cancer. What is prostate cancer? What is the prostate actually? What is prostate cancer? How common is it? What are the risks and symptoms? Who should be screened and why? And then how to diagnose it and what are your treatment options once diagnosed. But most importantly, this will be an information session to arm everyone with knowledge so you can ask questions at the end of the discussion and be able to make informed decisions when you're face to face with your physician. So we'll go through the first talk. I've got another set of slides, but we'll entertain questions in between the two talks. So what is the prostate gland? What does it do? The prostate gland is a male sex accessory organ. As you can see, it's right here at the base of the bladder, and it provides nutrients and fluid for sperm. The urethra runs right through the middle of the prostate gland, as you can see. So many people ask, well, what good is the prostate? I say, well, it's good until you finish having children. After that, only problems can occur. So it's kind of like the uterus in a female. What is prostate cancer? It's the abnormal growth of cells that grow out of control and which begin inside the prostate gland and can spread to other organs by local extension. It can spread lymphatically or through hematogenous route, through the bloodstream. So, does anybody know how common prostate cancer is? 1 in 3, 1 in 6, 1 in 12, or 1 in 24 men in America will have prostate cancer? Let's go with B. 1 in 6 men will have prostate cancer. Okay, to give you an idea of how many men that is, let's just suppose we're all at a Saints game and there's 75,000 men in the stadium. 12,000 of those men during their lifetime will be diagnosed with prostate cancer. And of those 12,000 men that are diagnosed with cancer, 3,000 will die from the disease. So, it's a very prevalent disease. Prostate cancer is the #1 solid organ cancer in man. It's the #2 cause of cancer death in men. So it's a very prevalent disease. What are the risk factors of prostate cancer? There's a myth out there that it's only an old man's disease. It happens in young men. Certainly the risk does increase as we age. However, we see it in young men as well. So, to give you an example, my youngest patient with prostate cancer that I've seen in my practice, and I've been in practice for 20 years now, is 34 years of age. So it's not just an old man's disease. What are the risk factors? Age is a risk factor, family history, and race. African American men are more than twice as likely, a 200% increase, to die from prostate cancer than non-African American males. So what are the symptoms that occur from prostate cancer? Well, these symptoms are not strictly specific to prostate cancer, but some of the symptoms include trouble urinating, weak flow of urine, frequent urination at night, sometimes blood in the urine or blood in the semen, bone pain, sometimes painful ejaculations. These are some of the symptoms. So what is another myth about prostate cancer? That if you have symptoms, or if you don't have symptoms, then you don't have cancer. Unfortunately, most of the time, if we don't diagnose prostate cancer until a man has symptoms, it's too late to obtain a cure. So, unfortunately, symptoms are usually a late sequelae in the disease process. So, what does screening involve? Well, prostate cancer screening involves mainly 2 things. Blood test, PSA blood test, which we'll go into more detail about the controversy and the specifics of that in the second talk. And then, of course, a digital rectal exam. Most men don't mind getting a needle stick, but the rest of them hate to get the finger, and I don't blame you. I tell my patients, if you enjoyed that, we'd have to find you a new doctor. So those are your two screening tests. Then, of course, we do get a history as well and check for symptoms. So another myth about prostate cancer screening. If you have an elevated PSA, doesn't automatically mean you have cancer. If you have a normal or low PSA, doesn't mean you don't have cancer. PSA is prostate specific, it's not cancer specific. There are many other things that can cause the PSA to elevate, not just cancer. So if you have an elevated PSA or an abnormal digital rectal exam, and you're a high-risk patient, and you get to the point where you need a biopsy, and a biopsy is obtained, and you have prostate cancer, well, what are your treatment options? And there are many options for prostate cancer. One is, there's two options that are non-curative. One is active surveillance, watchful waiting. Basically just keeping an eye on it, not ignoring it, but keeping an eye on it. An active surveillance monitoring process, basically we would do frequent PSAs, rectal exams, and periodically it would require repeat biopsies to make sure the cancer is not spreading. Who's a candidate for active surveillance? Well, patients who are at low risk, patients who may have a life expectancy of less than 10 years and have other competing causes for their death, such as severe heart disease, lung problems, peripheral vascular disease, other comorbid conditions. Those are the patients that are candidates for active surveillance, or sometimes just the patient who prefers no treatment at all. The other non-curative option for prostate cancer is hormonal therapy. Hormonal therapy, just as breast cancer responds to hormones in females, prostate cancer in man responds to hormones. And hormonal therapy is typically recommended if your cancer has spread. We know we can't cure it, the cat's out of the bag, but we can slow it down and oftentimes put it into remission for years with hormonal therapy. Other patients who are candidates for hormonal therapy are patients that may not be a candidate for more aggressive treatment. So those are your two options for non-curative treatment. Your two curative options are radiation and surgery. There's different ways to do the radiation, different ways to do the surgery. With radiation, basically you're talking about just killing the cells. You're not removing them, you're killing them and in place, and the prostate remains intact. External beam radiation or radioactive seed implants are your two options. Surgery includes removal of the prostate gland and removing the prostate cancer cells. Minimally invasive surgery with the robot is the most common way to perform a prostatectomy today, but some patients will still have the open prostatectomy as well. So basically those are your options for treating prostate cancer. The surgical therapy, total removal of the prostate gland, is typically recommended if you have a life expectancy of 10 to 15 years or greater and you're otherwise healthy. And those are the patients that are recommended to have it removed, because the long-term success, the long-term quality of life, and the long-term fewer complications are better with prostatectomy. So the other important thing to note is if you have a prostatectomy, you wouldn't necessarily know this if you choose radiation or non-removal of the prostate, and that is in up to a third of cases, when we get the prostate gland out and send it to the pathologist, there will be a change in the diagnosis or the grading system of the prostate, which means it can be more aggressive than initially thought. So that is of concern, and you don't always know that answer unless you have it removed. So thinking ahead, what if the prostate cancer returns? Well, I always tell my patients when discussing the options of treatment, and if they're candidates for all types of treatment and prefer a curative option, then one important concept is that if you choose surgery as your primary treatment, and God forbid the cancer returns at a later date, years down the road, you can still get radiation. Conversely, if you choose radiation as your primary treatment and the cancer returns years down the road, you can't have surgery. It's like operating on concrete. If you think about what the radiation does to the pelvis, it causes scarring and fibrosis. It can be done. It's called a salvage prostatectomy. However, it's a surgery that nobody likes to do, and it's fraught with complications. So it's typically not an option in most patients. To discuss a little bit about the newest technology, robotic prostatectomy, which again is how we're doing 80 to 90% of our surgeries today. It's, you look at the picture here, you can see the incision line beneath the belly button, or you can see the laparoscopic ports, which is like straw hole surgery, laparoscopic surgery. And when you compare the two, the reason most patients are opting for robotic prostatectomy is it's less invasive, it's quicker recovery, you tend to get a quicker return to continence, you have shorter hospital stays, less blood loss. So in the short term, it is a much better procedure. Not everyone's a candidate for the robotic prostatectomy, but if you are, most patients are choosing that option. So in summary, it's important to remember that, you know, going through all the information that we're going to give you today, what do you do next? Well, if you're 40 years of age or older, you should have a yearly PSA blood test and digital rectal exam. You should discuss with your primary care physician what are the risks and benefits for proceeding with prostate cancer screening. And if you've already been diagnosed, talk to your doctor about all the treatment options. And that's a personal decision. That's a decision between you and your physician, and ultimately you, the patient, makes the decision. Okay, so having said all that, that's sort of the introductory discussion. I'll open up the floor for a few questions, and then we'll move on to our next discussion, talking about specifically PSA and screening. Yes, sir.
Under active surveillance, what frequency do you recommend?
That's a good question, because there's some controversy. It's not set in stone as to how to do active surveillance. How I do it in my office is once I've diagnosed the cancer and the patient, whether he's a candidate for definitive treatment or he chooses not to have treatment, and we decide on active surveillance, then we will follow that patient every 3 months with a PSA blood test, and we will watch the numbers closely. We will also do digital rectal exams, and at some point in time, it requires repeat prostate biopsies. Some studies suggest as often as every 6 months. Some studies suggest you can do it as sparingly as every 2 years. So I kind of split the difference. I typically recommend to patients that will do active surveillance and we'll do a repeat biopsy yearly. Yes, sir.
Food groups or things that will cause more prostate problems than others? You know, they say like dairy products will increase this kind of stuff.
That's a good question. It's a Western diet in general that increases the risk of prostate cancer. There are many cultural studies that have shown that patients that come from societies and cultures with a low incidence of prostate cancer, when they become westernized, so to speak, on our diet, that it, they increase their risk of prostate cancer.
Anything specific?
Specifically, there's no real specific dietary contents that significantly show. I would never tell someone you can't eat something, but there are certain things that are very helpful in terms of preventive, and so you've heard about lycopenes. That's helpful. A lot of the tomato sauces and whatnot have the lycopenes, and that's beneficial. And there are some other studies to suggest that possibly selenium is helpful, and there's several vitamins that you can get out there that are specific for preventing or helping with chemo prevention. None of them are, of course, an absolute, but some of them are very beneficial. Yes, sir. Yeah.
If you had radiation as a treatment option the first time,
You cannot have repeat radiation once you've been treated with radiation therapy for prostate cancer. However, you can have hormonal therapy. And again, a salvage prostatectomy is a possibility in a few select patients, depending on the bulk of your disease, the type of radiation, your overall health, and metastatic survey. But that's a rare patient that would benefit from a salvage prostatectomy. And again, even if you are a candidate, it's got many increased possible complications.
I've got a 60-year-old friend who had it removed 2.5 years ago. He was told there's 90% chance it was fine. He calls me recently and says, I'm at 10%. It's come back. I'm doing radiation now. Is 90% a good figure on removal?
90% is an excellent figure, a figure upon removal. We have certain computer programs. The one I use is called EuroPredict, and it takes into account the patient's age. This is once we make the diagnosis, and we're trying to make predictions in terms of helping them be informed in making their decision on which treatment to decide upon. And the EuroPredict program takes into account the patient's age, their stage, the grade, whether or not the biopsies, whether or not the cancer was unifocal or multifocal, and it spits out a percentage of whether or not it's going to be organ confined, spread beyond the capsule of the gland, seminal vesicle involvement, or metastatic disease. And if you do this EuroPredict program or something like it, and you have a 90% chance, that's as good as it gets. I mean, that's great odds. Unfortunately, some people fall in the 10% category.
On active surveillance, there is some risk of infection, of course, from biopsy. Do you have any particular PSA level at which point you think that another biopsy would be mandatory?
Please define active surveillance.
Okay, active surveillance is watchful waiting. It's keeping an eye on the cancer. Many patients will choose, typically elderly patients, patients with significant comorbid conditions and life expectancies of less than 10 years or greater. It doesn't mean we ignore the prostate. We don't throw in the towel and say, oh, chances are you're going to die in less than 10 years, so forget about it. We follow these patients, and active surveillance means following their PSAs closely, digital rectal exams, and repeat biopsies along the course. And to answer your question, again, there's nothing set in stone. A lot of times it's a clinical decision, and it's the art of medicine, so to speak. Not everything's black and white. Sometimes it's gray. But in terms of doing repeat biopsies, yes, there are risks involved, and we do everything we can with preventative antibiotics so that you don't get an infection. But in terms of the PSA, typically if it doubles in a short period of time, absolutely those patients need to be rebiopsied. And, or if there's a gradual rise, we have certain standards that we look at. And that's what we call PSA velocity, change per unit time.
You don't have any standard in terms of the absolute level?
No, not the absolute level, because in some patients, PSA of 10 is much more significant if you have a small gland of, say, 20 grams than a PSA of 10 in a patient who has a 100-gram gland. And so that's what we refer to as PSA density. So a lot of factors have to come into consideration in the individual patient's decision. How involved is the biopsy?
How involved, he's asking.
Right. The prostate biopsy is an office examination. You walk in, you walk out. What I tell patients what they will experience is about what you experience when you have a rectal exam, okay? Now, the reason is because we do what's called a perineal nerve block in our office, and we use some lidocaine to numb up the perineal nerves, and there's one on each side of the gland, so that you don't feel it, similar to a dentist numbing up your gums before he gives you your cavity filling. And so what we'll do is we'll do the perineal nerve block, and that stings a little bit when you inject it, but once you do that, you don't feel the biopsies. However, you still feel the presence of a probe in your rectum, but it's just sitting there. using ultrasound technology to visualize your prostate on a screen.
Explain what's going on between what you're presenting and what I learned at the Veterans Administration when I had an annual exam. When I reviewed it with them, I asked them, what was my PSA? And they said, we don't do PSA on people over 70. And that was 2 years ago. And what's going to happen in the future? And why did they cut it out?
Herein lies the controversy. We're going to get to that with our next slide show. If that's okay with you, I'll defer that question and ask it again if I didn't answer it properly in the slide discussion. And how does it affect what? Well, colonoscopy, I'm glad we have Dr. Chastain in the audience, but typically it's my understanding that you start a colonoscopy at age 50. Unless you have a family history, you start at age 40, and they typically will do it every 5 years unless they find pathology. They may do it more frequently. Is that good enough, Curtis? Yes, sir.
I know you said for detection, the earliest you had is age 34, and I know there's probably no answer, but is it any average range when the cancer may appear, prostate cancer may appear in patients in your practice?
Yeah, the mean age is somewhere close to 60 to 65. Yes, sir.
I had a friend that almost died from the complications from the biopsy. How many patients normally will run into problems?
That's a very good question. And, unfortunately, almost anything we do in surgery and medicine and procedures, there are inherent risks. And you have to weigh the risk-benefit ratio when you make a decision of whether or not to have a biopsy. I will tell you, knock on wood, I've never had anybody die from a prostate biopsy, and I've been doing it for 20 years in private practice and 6 years of training before that. Having said that, I have had several patients have to go in the hospital with a severe infection where we have to treat them with IV antibiotics for several days before we let them go home. And that happens maybe once or twice a year. So there are risks involved, and we do everything we can to prevent infection. Another possible risk is bleeding. And it's rare, but 1 or 2 patients a year will have to have the gastroenterologist go in and cauterize a little point of bleeding that won't stop inside the mucosa. It's not a severe amount of bleeding, but it's enough to where it needs attention. It needs to be addressed.
Could you explain PIN, and can PIN go away?
PIN stands for prostatic intraepithelial neoplasia, which is just a fancy pathologic term for tissue that is abnormal. The glandular architecture and cellular architecture is abnormal to the visual inspection of the pathologist. It's not severe enough to call it a cancer. However, most studies suggest that PIN increases your risk by 70% of becoming cancer, of developing cancer. So it's considered a precancerous lesion.
Can it go on for a long period of time?
It certainly can. And in those patients, instead of seeing them yearly, I'll follow them every 6 months. And so it does require an increased surveillance program, but it's not cancer. However, it's not completely normal, and it is precancerous and increases your risk.
Could it ever go away? Not really, probably.
No. I mean, once you have PIN, you have PIN. I mean, you have the diagnosis, so it's there. And even if you had a repeat biopsy down the road that showed no PIN, you still have it. Okay. Yes, sir.
You kind of nonchalantly went over the robotic or surgical removal of the prostate. Trying to define it as when a man gets old enough where he doesn't have children, doesn't want to have children anymore. Does that not have an adverse effect on your sex life?
The robotic prostatectomy?
Any kind of prostatectomy.
Any kind of prostate cancer treatment.
No, I can't. If a man just wants, as a precaution, to have his prostate
Okay, well, I will just say this. If you show me a urologist that's taken out a prostate as a precaution without the diagnosis of prostate cancer, I'll show you a urologist that's committing malpractice. No one removes a prostate gland as a precaution. If you have the diagnosis of cancer, then you have treatment. But, I mean, that's a good question. I mean, we all want to prevent things, but no one would be taking a prostate gland out or go through the risk of possible complications of any kind of treatment, whether it's radiation or surgery, just as a precaution. Okay, so we're at 10:30 now. I'd like to move on just to the second set of slides because I want to go over some of the controversy of PSA testing, and then we can fall right back into a question session. You're asking very good questions, and I really feel as though that's where we get most of the knowledge out to the audience. So if I skip over things or nonchalantly go over something too fast, please ask those questions at the end. Okay. The U.S. Preventive Services Task Force and Prostate Cancer Testing. The USPSTF is the acronym. Let's see here. I'm having technical difficulties on how to move to the next slide. Our audiovisual guy in the room? It's not allowing me to do that. I need to get back to the split screen. So it's not doing it. And I can't go to the next slide. Okay. Yeah. Any other questions while we're doing this?
Good to go.
Yes, sir. I'm sorry, could you repeat that? Right, the ultrasound. No side effects to ultrasound. It's not radiation, it's a benign diagnostic test. That's correct. It helps us detect cancer. It helps us two ways. It helps us in terms of visualization of the gland and cancer, and it also helps us with mapping out the prostate to get the needle in the appropriate position. Okay, so the USPSTF, Preventive Service Task Force, and prostate cancer testing. This will speak to your point at the VA and what is recommended by the USPSTF. Before we start talking about the recommendations, let's talk about what the USPSTF is. It's an independent council assigned by the federal government to look into preventive care services. You may recall that a few years ago they came out with a recommendation to primary care physicians to no longer use prostate-specific antigen, PSA, for screening. This panel is made up of primary care physicians and public health professionals. There are zero medical oncologists, radiation oncologists, or urologists on this panel, so no one who treats prostate cancer on a daily basis was involved in this decision-making process. Needless to say, the American Urological Association takes issue with these recommendations, and we'll go over that. And the American Urological Association has come out with their own stance. And interestingly, when they made the decision for mammograms several years ago, they came out with the same recommendation, that mammograms were no longer necessary for screening for breast cancer. Well, guess what? Women are a lot more vocal than you men, and they actually complained enough and had enough medical and public and political outcry that they rescinded that recommendation. And they have not done so yet with prostate-specific antigen. So if you disagree with that recommendation, then let your voices be heard. It's unfortunate because this recommendation is recommended to a population level, and it's something that's implemented on a personal level. And as you can see from all the discussion we've already had, that there's so many components, so many factors that go into the decision-making process. It's an individual decision between the patient and the physician and your specific situation. So it's not straightforward. I mean, if you think about what are the goals of prostate cancer testing, it's not just to prevent death. It's, of course, that's what we hope to avoid, is someone dying from prostate cancer. And so the goal is not just to prevent mortality, but it's also to prevent the attendant morbidity. And when I talk about morbidity, I'm talking about all the complications that we see with prostate cancer and the spread of prostate cancer. Urinary tract obstruction, obstruction to your kidneys, obstruction to your bladder, in and out of the emergency room with blood clots requiring catheterization, pathologic bony fractures from the spread of the cancer, significant bone pain. So there's a lot of attendant morbidity that goes along with prostate cancer that we would like to avoid. So screening is not just to trying to prevent death. So if they tell you, oh, we're only preventing 1 death out of 100, then, you know, how do you decide, you know, who that one person is? But in any case, the most effective way to prevent this advanced metastatic cancer is early detection. So let's talk a little bit about the prostate cancer itself. And some of this I'm reiterating from the earlier talk. But we are unable to determine which patients are going to die from cancer and which patients are going to die with prostate cancer. Okay? Again, remember, it's the number one cause, it's the number one cancer in men in solid organs, and it's the number 2 cause of cancer death. But you've also heard the phrase, many men die with prostate cancer and not from it, and that's certainly true. Many cancers are indolent. Unfortunately, the only way to know if either one of them exists is to test for it. And we don't have really good testing right now to determine which ones will be the very indolent cancers. However, there's a lot of exciting genetic testing going on right now that hopefully in the future we will have genetic markers that will tell us which ones are the more aggressive cancers. But right now what we have to deal with is the PSA test. And when it's used appropriately and when it's interpreted properly by your physician or your urologist, then it's a very, very useful tool. Before the PSA era, unfortunately I can speak to the entire PSA era because that's how old I am. Okay, I've been practicing for 20 years now. PSA came out right when I started my training. Okay, late 80s, early 90s. And before the PSA era, all we had to utilize to diagnose cancer, as I mentioned earlier, were your symptoms and a digital rectal exam. We had nothing else. Remember what we talked about? If you show up with symptoms, it's usually too late to effect a cure. There's still treatment, but rarely a cure in those patients. And symptomatic tumors that showed up, they showed up in a higher grade and a more advanced disease. When I was a resident, more than 50%, upwards of 70% of patients at the time of diagnosis were metastatic cancers. Today, that's less than 15%. So, and that's the PSA era. So, in my opinion, it would be a travesty not to allow the patient and primary care physician to still utilize PSA testing for prostate cancer screening. The SEER data, of course, like we talked about, showed a 75% reduction in the proportion who present with metastatic cancer and a 42% reduction in the age-adjusted mortality over the past 20 years. So it has been a very helpful test. PSA is not black and white. Obviously, you got that by now. We've talked enough about it. PSA is not a black and white issue. Not like something, for example, a CBC blood test, checking your hemoglobin hematocrit to see if you're anemic. Okay, it's a cut and dry number. Either you're anemic or you're not. PSA, it's not cut and dry. We mentioned a little bit about PSA velocity, PSA density, age-specific PSA. All these factors have to come into consideration. in addition to the patient's individual situation. So because of all these controversies, the American Urological Association, and I've got to tell you, there's a lot of medical associations out there, and I've been members of several, and I am most proud to be a member of the American Urological Association because they are a very proactive group, and they really do some crackerjack investigation and studying and recommendations. Recommendations for what it takes for us urologists to remain board certified, and recommendations on best practice management, how to deal with patients in your practice on a day-to-day basis. This best practice management, the American Urological Association guidelines are things that we follow on how to take care of patients. And the American Urological Association, of course, still recommends that at age 40, you begin with a yearly PSA blood test and a digital rectal exam. And if after discussion with your physician that you proceed with screening, and then if you're diagnosed with prostate cancer, then you need to be informed of all the risks and benefits of not just screening but also treatment. So who is at the highest risk for prostate cancer? We talked a little bit about this. African American males, family history of prostate cancer, or if you have a PSA of 1 or higher at age 40. So just remember that a prostate cancer diagnosis doesn't automatically mean you get immediate treatment. But the bottom line is that you can't make an informed decision about cancer if you don't even know if you have it. So with that, let's open up the floor for more discussion.